Hi again, everyone. Glad to have you join us for another pre-class video for EBP. Now that you've gotten your feet wet with understanding some of the basics of causal inference and thinking, we're going to launch into our first study design that we're going to consider together, the randomized trial, which is a type of experimental design that's critical in our field. It's a good one to start with because randomized trials are intuitive, if not challenging to execute, and they easily lead us to think critically and clearly about potential causal mechanisms. To give you a sense of where we're headed in the study design unit from here, after this unit, we'll focus on the next couple of sessions on observational study designs and ways to interpret measures of association in several clinical contexts. Today we have two primary learning objectives. The first is to describe the fundamental design elements that underpin a randomized trial. These include a lot of logistics, but most of what we'll talk about today are the three major elements: randomization, blinding, and analysis strategies. The second objective is to define the strengths and limitations of randomized designs. In our in-person class session, we'll review these principles and practice interpreting results from randomized trials. Similar to our lecture on causality, today's lecture will also have a through-line clinical example that gets brought up at several points. I've adapted and simplified this example from a study that was published a couple of years ago, which is a non-inferiority trial. This is a type of trial you'll learn way more about later in this course. For this example, here's our PICO. We're interested in a population of patients who have a serious, acute or chronic bone or joint infection, and who under normal circumstances would be treated with approximately 6 weeks of intravenous antibiotic therapy. This is a topic that's near and dear to me, as much of my work focuses on osteomyelitis and diabetic foot infection, which is a type of infection that primarily affects bone marrow and leads to extremely painful swelling and very serious downstream effects on patients. In this example trial, the intervention and comparator are treatment with oral antibiotics versus a comparator of intravenous antibiotics, which was the standard of care. The hypothesis of the investigators is that oral antibiotics will not be any worse at delivering positive treatment outcomes than intravenous antibiotics. The outcome of interest in this study is treatment failure within 1 year, meaning that the infection was not resolved. Briefly, I want to bring up one of the key points from last lecture, and that was all regarding our embrace of the counterfactual theory for understanding and criticizing causal associations. As you remember, when we think that an exposure may be beneficial or harmful, we can posit a research question that asks, what if we provided a different type of exposure, contrary to the one that we actually saw? Would it give people a different experience with the outcome of interest? One of my goals for this presentation is for you to see how randomized trials get us toward thinking of this idea and mimicking the counterfactual. You'll also remember that to apply counterfactual theory, if circumstances are right, we can find substitute populations who can stand in as equivalent counterparts in a competing exposure group. We think of them as stand-ins because other than the exposure, they have really similar characteristics to the people who got exposed. If the substitute population breaks any of the three essential rules of causal inference, then you got problems interpreting your estimate as one of a causal association. One undeniable fact is that randomized trials are one of the best types of study designs for establishing knowledge or providing evidence of causal associations. When there's uncertainty about beneficial treatments, which we refer to often as equipoise, experimental designs like randomized trials, if performed well, can give us extremely important insights that we could not garner in many observational settings. Why are randomized trials so useful? They do this thing that we talked about last time. They do a really good job of identifying and leveraging a substitute population. This helps us adhere to the causal inference rules of positivity and exchangeability. They also enable us to make meaningful comparisons across exposure groups that we really think are comparable to each other. They encourage us to lay out exactly what we plan on doing in our intervention, how we plan to intervene on patients, and this helps us stick to the consistency rule of causal inference. Finally, because randomized trials are also prospective in nature, and subject to extremely detailed protocols ahead of time that need to be approved before the study is implemented. There's a very clean temporal association between exposures that are delivered through the intervention and the outcomes that are observed after. It almost goes without saying, but randomized trials are a type of intervention study that involves the random assignment of different interventions to people who are enrolled in the trial. Who are these people enrolled in the trial, though? That's one of these key questions that we have to ask. Does this trial population mirror the target population that we care about? What is the outcome, and what's the outcome that we hope to prevent if it's a bad thing, or promote if it's a good thing? In the trial planning, outcomes have to be very clearly specified so that study staff know exactly what they should be assessing for during follow-up. As I mentioned earlier, we speak about ethics and the utility of a randomized trial, and if there's not really an authentic uncertainty or equipoise about whether or not an intervention could benefit the population or a specific group in the population, then a randomized trial is probably too late to the party. There's probably already too much knowledge out there for any randomized trial to A, garner the funding and support to be conducted, or B, more importantly, to move the needle with regard to clinical practice. One nuance related to the idea of whether or not there's real clinical equipoise has to do with exactly what the intervention is going to be compared to. Depending on what the current state of knowledge is, like whether or not the competing treatments are already on the market, it may be useful to conduct an active comparator randomized trial instead of a placebo-controlled randomized trial. As we turn back to our through-line clinical example, we can see that this trial posited an active comparator instead of a placebo because there was so much knowledge about ways to treat these kind of bone and joint infections at the time that this trial was conducted. It would never be ethical or reasonable to give any of these infected patients nothing but the placebo effect. You can also note from this example that the intuition gained from an active comparator design, even in a trial, helps us enroll exactly the kinds of patients that we intend to study and examine head-to-head benefits of competing treatment regimens. So taking a bit of a step into randomized trials and how they actually unfold, I think that one helpful way to start thinking about them is through the lens of a patient's perspective. Here we see the timeline from a patient point of view. Sometimes I'll refer to these as participants and sometimes patients. In terms of their engagement in the trial itself, the patient will be enrolled and randomized to a treatment group, and they'll be given this treatment of interest. And then after being randomized, they'll be followed up to assess for the outcomes that are of interest in the study. They'll be monitored for whether or not they're actually maybe experiencing positive outcomes from the medication. And they'll also be monitored for adverse events or side effects from the medication. One really critical consideration that we always have in clinical research is what a patient history was before we got to work with them. In the trial setting, that patient history before we got to start seeing them in our trial is what we refer to as the baseline. This is indicated in green. This is the time period where social and all kinds of other history is building upon itself and leading this patient to the point of being in our trial population. Maybe they have advanced cancer and are searching for a chemotherapeutic regimen that will finally work for them. Maybe they're a healthy undergraduate student who finds it very appealing to get paid $50 to answer questions and have their blood drawn twice. I use these two extreme examples, and particularly the second one, which I know might come off as silly, just to underscore how important it is that we understand the characteristics of how the participants in any trial actually arose. Now that we've talked about what a trial looks like from a patient perspective, it's really helpful going forward for us to think of what that patient perspective and how it fits into the investigator's perspective when planning and executing a trial. This will also help as you read trials to think of how they were actually planned and implemented. First, before any patients ever get involved, the investigative team is tasked with planning a clear and useful trial. They need to come up with a clear study question and identify a target population that corresponds to the question, and really identify how many people they need to have in their trial in order to answer the question from a statistical point of view. Additional planning regarding the recruitment and enrollment of patients includes inclusion and exclusion criteria that need to be very clearly specified, and informed consent procedures to protect patient rights. Finally, and what we'll spend most of the time in this presentation talking about are the procedures for randomizing patients, blinding exposure allocation, and planning analysis so that the analysts can answer questions about treatment effects that they really care about. Once those plans are outlined by the study team, then it's time to start the implementation phase of the trial. I start by pointing out some of the milestones along the way that are key for an investigative team to have established before they implement the trial. Some of these milestones along the way are interim data analyses and reporting periods to monitor the potential benefits and harms of the study treatments. Typically, studies will be evaluated by what is referred to as a Data Safety Monitoring Board, or DSMB, which is an independent advisory board that consults the study team regularly and oversees the execution of the study. These interim data and analysis reports provided by the study team are critical to this process so that the trial can be halted early if the intervention appears to be causing unexpected harms, or it could be halted early because that trial may be demonstrating such a critical benefit to patients that it would be unethical to go forward with the trial and not get these therapies out into the world for patients. The last milestone on the right is the most common endpoint for a trial. It's the time that the trial is concluded, data are compiled for the entire trial, and the findings are published and shared with the public. The whole time of this implementation process is going on, the study team is managing the influx of patients into the trial population. Each of these bars represents one patient experience, which we detailed in the prior slides, just to show that there are many moving parts and interactions with patients at different time points along the study period in the investigative team's life. This slide presents an example of a figure from a landmark trial that is the basis of our clinical throughline example for today. This figure is a schematic that is used to lay out all of the engagement with potential trial participants through their possibility of being considered for the study, being evaluated for eligibility, actually being enrolled, and the process for randomization and allocation of exposure. I think it's really important to lay this out to note how complicated this is and how many different measurements and considerations went into developing this population that these people would study. Also note that this is only the top part of the figure. Lots of credit goes to these researchers and many like them who do a fine job presenting their information on their study population so clearly so that we can understand the strengths and limitations of their given studies. Now that we've covered some important characteristics and layout of a randomized control trial, this might be a good time for you to pause the video. After your break, we'll come back to discuss 3 important strategies for maximizing the utility of randomized trials. So now that we've talked about some of the strategies that underpin the question that people are asking when they conduct a randomized trial, we'll get into 3 of the big strategies that need to be clarified and implemented for carrying out a successful randomized trial. These are randomization, blinding, and analysis of data. Because randomization ensures that confounding factors are equally distributed across exposure groups, we can infer from a randomized trial that observed differences in outcome occurrence is due to the exposure and not a confounding factor. Randomization is typically performed in 4 ways, which we'll talk about on the following slides. But the 2 in the middle are stratified and blocked. And these 2 are especially useful when there's a limited sample size in a trial. Using these types of approaches is something you'll probably come across when reading the literature, and typically you can think of them as efficiencies that tend to uphold the most meaningful implications of randomization. Remember that randomization is by definition subject to random error, so the larger the sample size, the better randomization will perform. The first and simplest approach to randomization is what we refer to as individual and often simple randomization. This is the easiest type of randomization to think about. Each individual goes through a coin flip process to assign their treatment. Using our through-line clinical example, we know that we have two exposure arms, oral or IV antibiotics, and we expect that a fair coin will randomly allocate patients to one of those two groups. Of course, in reality, these types of randomization processes, even these simple ones, are done with computers. The second randomization approach is called stratified randomization. This is just a slight variation on simple individual randomization. When you're really concerned about having a potentially small sample size in your trial, and you want to make sure that you don't overlook some key factors, you can subset your trial population by those key factors and then perform a randomization process on each of those groups separately. Using our clinical through-line example for today, we're often very concerned about patients with bone and joint infections who have type 2 diabetes. They have a lot more medication use, they're a lot sicker in general, they're often older, and they have many characteristics that lend us to be more concerned about them. If we wanted to study effectiveness and safety of oral versus intravenous antibiotics, we may very well want to interrogate whether there were differences in treatment effectiveness and safety by diabetes status, and we would definitely be compelled to make sure we controlled for potential confounding by diabetes status at baseline. Subsequently, we defined during the baseline period all the patients with type 2 diabetes, and then we perform the coin flipping procedure on them to allocate those patients toward oral or IV antibiotics. Then we can do something similar with the patients without type 2 diabetes. We can identify them to receive either oral or IV antibiotics. We'll flip the coin and assign them just as we would have otherwise. By doing this process, stratified randomization, we will ensure that each exposure group has a roughly equal number of patients from each diabetes group, and we therefore won't risk having imbalances by diabetes status across treatments. If we have a very large trial population, then stratified randomization is not really necessary because of the law of large numbers. With so many coin flips, we'll end up doing okay with balance. The third approach to accomplish randomization is called blocked randomization. The motivation for this is similar to stratified randomization. When you're concerned about and you want to promote a random and fair balance of patient characteristics across treatment arms, this might be the one. This is a complicated one to talk about, but much easier to understand when you actually see it working. So the first thing is that the study team has to decide how many patients they plan to enroll in their trial and at what pace. They also have to enumerate their treatment arms. This could be 2 or more depending on the study question. Adapting our clinical trial example for today, let's say we plan to enroll 400 people into our trial and we have 2 treatment arms, oral and IV antibiotics. Based on our trial size and our time frame for rolling out the trial, we've decided to make blocks containing 4 people at a time. Next, we need to list all the possible sequences that treatment could be evenly allocated to each block of 4 people. We'll use yellow blocks to show oral antibiotic allocation and orange blocks to show intravenous antibiotic allocation. So there are 6 possible sequences. Believe it or not, I did not plan this out, but this example just lends itself perfectly to the idea of using a 6-sided die to make our randomization process a reality. I just labeled each of these sequences using the marker from the die as we move forward with this example. Each time that I roll the die, I mark down the number that I rolled, and I look over to the chart to identify what that number really signifies. It signifies one of these random sequences of treatments that I'm going to allocate as patients enter my study. So for the first time, I rolled, I found that patient 1 will get oral, patient 2 will get IV, patient 3 will get IV, and patient 4 will get oral. So now I need to roll the die again to identify what's going to happen to patient 5 through 8, 9 through 12, etc. As we go through the process, we can see that our rolling of the die is laying out our recipe for what we're going to do for treatments for every single patient in our trial before we ever even know who they are. Importantly, I stop here to show that say we're only going to complete a trial with 20 patients, maybe a small single-site trial for patients with a rare disease. This blocking procedure would allow us to make sure that even if we only had 20 patients, we would be pretty much guaranteed to have 10 oral patients compared to 10 IV patients. If we left this up to the idea of flipping a coin in kind of the simple setting, we probably would not get this lucky. Now moving forward to complete the process for our trial population of 400, I've only taken care of 20, so I need to roll the die 95 more times to lay out the treatment allocation plan for all the other patients that we plan to enroll. Once the process is done, we will have guaranteed that our treatment arm will have almost exactly 200 people and will definitely be tired of rolling a die. So thank you, computers, for making this happen. The final randomization approach of the 4 takes a totally different tack. It allows researchers to ask questions not about people, but rather about groups of people or systems. Some examples of when this is useful is for studying healthcare systems, hospitals, healthcare providers, or geographical groups. We can think of these as ecosystems that maybe could benefit from a positive population-level intervention. So instead of randomizing individuals, this process allows us to randomize systems to one intervention process instead of a comparator. And then we can answer questions that might have to do with system-level impact or a higher-level impact. Using our clinical throughline example for today, let's run through a trial about bone and joint infection treatment at UNC. But let's say that we don't have enough patients that we see at UNC to actually run an efficient trial in the necessary amount of time. So fortunately, we collaborate with Duke and Wake Forest and the Medical University of South Carolina often. So I could reach out to collaborators at those institutions and ask if they want to team up on a trial so that we can leverage all of our patient populations together. But one really important aspect to think of, which deals with this issue of multi-site studies and trials, is that in reality, each of these health systems is kind of a cultural universe to itself. There are norms and prescribing behaviors, differences between the ways that staff work with each other, for instance, that may influence the potential impact of an intervention like this because of the differential levels of acceptance of the idea in the first place. Some groups might just be more resistant to changing their practice than others. So to address these differences in norms, but still get the trial done, I might ask the question, what if I randomize 2 of these medical institutions to provide more oral therapy instead of intravenous antibiotics? And what if I randomize the other 2 groups to kind of continue as they were with the standard of care? To make this randomization process happen, I need to randomize these 4 institutions, not the individuals. To make this happen, one really good way to do this would be through cluster randomization. Since we only have 4 units to randomize, we need to be very thoughtful about how we allocate the intervention to those 4 groups. In the top example here, I suggest that we could use stratified cluster randomization to make sure that we don't put Duke and UNC in the same intervention group, since we think there's so much helpful comparability between those institutions. In the bottom example, I suggest that potentially one could argue that blocked cluster randomization would be good. You'd have to assume then that all the institutions are just as comparable to each other as any of the other ones in this group of 4, but then you'd be assured of having 2 institutions in each intervention arm as well. So we just went through a lot of content about 4 different ways to conduct randomization. It is totally true that randomization is very key to executing a good randomized trial, but don't let the fact that we only have 1 slide on blinding lead you to think that it's not important too. Blinding, which can also be referred to as masking, is a really important procedure that is often incorporated into randomized trials. In principle, this is simple. If a patient knows what treatment they've gotten randomized to, they might respond differently compared to if they didn't know. For example, if they got randomized to a placebo and they find out, they might feel left out and could seek the treatment elsewhere, or at least be demotivated to continue in the trial. If a clinician knew the treatment that their patient received, they might pay a bit more attention to the experience of their treated patients versus their placebo patients, just as an example. And if an analyst of data knew which patients in their data set received which types of exposures, there's a possibility that they could analyze their data differently from how they would have done had they been ignorant of the true allocation of exposure. For these reasons, there are 4 different types of blinding that we may see in studies. Sometimes there's no ability to blind a study and no intention to do so, because these are often referred to as open label studies, and everyone maybe needs to know what everyone is getting, and that's part of the trial design. Beyond that, studies might be single, double, or triple blinded, with these 3 classes of people being the groups potentially being blind. A brief note about this table is that it's possible for a single blinded study, for instance, to blind only the data analyst to the exposure allocation. This might happen if participants in a study are easily able to observe what type of exposure they got, say being given an oral versus an IV antibiotic. The study staff would have to know that as well. But there's no real need for the data analyst to know that, and it could offer one protection against information bias. Indeed, in our clinical throughline example, this is the type of blinding that occurred. Before we move on to the final component of randomized trial design, this might be a good time for you to take your last break and pause the video. So here we're going to focus on analysis of data from randomized trials. There are 3 common approaches that you need to be aware of for when you're reading the literature. The first is called intention to treat, the second is as treated, and the third is per protocol. For each of these analysis strategies, we've provided a table that provides a parallel summary of what the research questions that are being asked are, what exactly the effect is that each of these is estimating, what data they're using to answer those questions, and what the comparisons are that are being made, as well as some additional considerations. Starting with the intention to treat, or ITT estimator, this is asking the simple question, did the 2 randomized groups experience different outcomes, or did randomization affect the outcome? This might sound like a silly question, but it's at the heart of the randomized controlled trial design. So let's dig into it a little bit more. I think it's really helpful to break down the intention to treat estimate into all the assumptions that go into it. First, let's remind ourselves that the whole reason we're doing this trial is to find out whether or not exposure causes an outcome. Based on all the thinking and planning that we did, as discussed in the prior section of this presentation, we think that randomization is going to work in our trial, so that when we randomize people to a certain treatment group, they'll be given that treatment, and hopefully we'll take it. Also, thanks to our assumptions related to blinding that we've done, we think that randomization itself cannot be associated with patient outcomes. This is indicated by the lack of an arrow directly from randomization to the outcome. So given these 3 pieces, it's our hypothesis and our planning and execution of how we've rolled out the trial, let's say that in our actual trial population data analysis, we observe an association or a correlation between randomized treatment and patient outcomes. To be clear, we see an arrow from randomization to the outcome. Do we really think that the coin flip caused a difference in the outcomes? So no, of course we don't. This is why we designed the study this way. Because if we see an apparent association between randomization and the outcome, we can interpret that correlation as a causal effect that was set in motion by the coin flip and then made real because of the presumed effect of the treatment of interest on the outcome. In other words, we know that the coin flip should not actually impact patient outcomes. We also know that a coin flip is not impacted by patient characteristics. It's just a coin that gets flipped the same for everybody. Last, we know that blinding of treatment status was successful, or at least we're willing to assume so. If those three things are true, and we see a difference in the outcome between coin flip values, then that implies that there's an unconfounded causal association between being randomized to that exposure and the outcome. So we return to that pretty heavy table that provides information on the ITT estimator and how to interpret it. So what this ITT is estimating is the effectiveness of a treatment in the so-called real world. It uses data from all randomized participants and compares the outcomes across these two groups, no matter whether they actually ended up taking the medication or not. Depending on your perspective and why you're running a trial, you might see this as a good thing. It gives you the ability to let humans be humans and not exert too much control on their behavior. Also, really critically, it honors randomization that you performed at baseline, and therefore controls confounding by design. An important issue about the ITT estimator, though, is that it depends in part on whether or not the participants actually adhere to the treatment they were randomized to. Say you have a miracle drug that's extremely painful and needs to be taken over a long period of time to work. It might be biologically plausible that it could be a useful treatment for this condition. But if it's too painful and difficult for patients to actually use, then it will not be effective in the real world. Because adherence to medication is often a huge problem in clinical research, there are some alternative estimators that we can use in trials that can help us answer questions about the potential efficacy and benefit that interventions might confer, not just this real-world effectiveness from the ITT. So we turn to those now. The first one that we'll talk about, number 2 on our list, is as-treated approach. This as-treated approach, or what I might refer to as AT, asks a different question from the ITT. It asks, what was the effect of taking the intervention treatment as directed? Or alternatively, what could the effect have been if patients had adhered to the treatment? Because the as-treated approach analyzes data from participants that were adherent to treatment, it estimates what the potential efficacy of a treatment would be if perfect adherence had actually been observed in the trial population. In essence, this approach reclassifies patients based on what they received and uses sophisticated analysis procedures to compare outcomes based on what patients actually got rather than what they were randomized to. The third approach is somewhat similar to the as-treated approach. It's called per protocol. It asks, what was the effect of taking the treatment as directed as long as we observed people taking it as directed? So once a patient diverges from being adherent to the therapy, we stop collecting data on them and stop analyzing that data in the analysis of the per protocol estimator. So essentially, we follow them until they stop doing what they were randomized and intended to do, so that we don't pay attention to what goes on after they've stopped taking therapy. Similar to the as-treated approach, the per protocol approach estimates the efficacy of treatment, assuming that adherence in the trial population represents what we would see adherence be in the target population. Talking through these 3 analytic approaches, we've gotten a taste of what these are and what they do and don't ask. So to summarize the key points about these 3, it's important to know, first of all, that all 3 of these approaches are often relevant. They complement each other, and they help us understand different aspects of a potential intervention impact. The second big take-home point is that the reason they're so useful is because each of these estimates helps us understand the bounds of the potential impact of an intervention. The intention to treat is often the minimal impact that we could expect, and the as-treated and per protocol estimates provide insight into what could be the impact of the intervention if accompanied by high patient adherence. Third, the only one of these analysis strategies that aligns exactly with randomization and controls confounding at baseline is intention to treat. As treated and per protocol designs are useful, but they tweak the research question and leverage observational study analysis methods instead of the randomized study design. I'll conclude this presentation by discussing some of the strengths and limitations of randomized trial designs. The most important strength of randomized controlled trials is that they have a high capability for delivering internally valid results when we're looking for causal interpretation. As discussed, the intention to treat approach confers all of the benefits of randomization at baseline, so that there is no confounding at baseline between the intervention and comparator group. The consistency rule for causal inference is very clearly laid out in randomized trials. There are clear protocols provided so that the intervention can be implemented in a replicable manner in the trial itself and also potentially in external populations. Finally, the blinding of participants, study staff, and data analysts can limit information bias by design. There are also some key limitations to randomized trials. As we alluded to in the first lecture on causality and bias, the generalizability of randomized trials can be limited. It's important to interpret randomized trials as often internally valid, but potentially not appropriate sources of information for the target population that you're interested in understanding. Two examples of this are that trials may assess effectiveness of a medication for one indication, when you're interested in its effectiveness for another indication that may be highly relevant and plausible. Another example is that the populations who enroll in trials are often different, healthier, younger, and more engaged than target populations who actually need treatment in the real world. The second major limitation is that randomized trials are only appropriate and ethical for exposures that can be randomized. If an intervention were clearly beneficial, then it would be unethical to withhold that beneficial intervention from patients in need just for the sake of studying it in a trial. On the other side of that coin, to understand the adverse effects of harmful exposures, it would not be ethical to subject patients to potential harms for the sake of quantifying just how harmful it is. Randomized trials are often too small and select to detect rare outcomes, many secondary outcomes of interest, and potential safety concerns associated with medications. Also, especially for the pharmacists in the room, randomized trials are often too small and simple to detect drug interactions. This is the other edge of that sword related to how nice randomized trials are for upholding the consistency rule for causal inference. To do so, they have to be very straightforward and clear with what the intervention arm or arms will actually do. There's often not much wiggle room in classic randomized trials to incorporate multi-level drug interactions. Randomized trials are often too short to detect long-term effects. There are some notable exceptions to this, but normally trials do not last more than 2 to 5 years at the most. And why are trials often too short to detect long-term effects? It's tied into the idea that they are extremely costly. I put a little joke here with like my Lonely Planet pricing guide that I think only actually goes up to $3 signs, just to show that the cost and the relative cost of trials compared to observational studies is often excessive. So a little quick flashback to the last lecture, just to bring back a point that I alluded to. Remember how I mentioned that in our through-line example where we were talking about amoxiclav versus ciproflagyl for dealing with diverticulitis and C. diff infection, where that outcome of C. diff infection would not lend itself to be studied in a trial. This is because adverse drug reactions like C. diff are rare. So the ability to enroll enough patients in a randomized trial in order to detect a potential difference of a biologically plausible adverse drug event across these treatment groups would be extremely low and extremely expensive. I hope that this presentation has laid a helpful framework for understanding randomized controlled trials. I look forward to seeing you in class where we'll practice interpreting the results from trials and understanding more about the benefits and trade-offs of this design. See you then.